This episode of the Overrun podcast is brought to you by Team Life. Your hands can save a life. Learning how to perform high-quality CPR can be the difference for someone experiencing cardiac arrest. Team Life offers CPR certification classes throughout New Jersey taught by trained professionals. Sign up today for CPR certification classes at teamlife.com and learn the skills necessary to save a life. Anyone can be a hero. Now back to the show. Hey everybody, welcome back to the Overrun podcast. Ed Bauter here. Dan Schwester is working on the truck saving some lives, and this is our year-end special. We have our medical directors, Dr. Mike DeFilippo, Dr. Michael Stone. Hey guys, how we doing today?
Fantastic. Yep, doing great.
It's the first show that we've done with these guys. Now they're the West Coast heroes for the time being, but they were good enough to come up with some of the five of the best papers that they found this year. And I'm really excited to hear you guys talk about these because some of them seem really interesting, some of them are really important. We're going to get into what's practice changing and what's not. So, Mike, let's go ahead and start here with this non-invasive ventilation and pre-ox paper we see here.
Which Mike?
Oh,
I had a feeling you were talking to me.
Too many mics.
Yeah. So, hey, everybody. Glad to be here again. So we just essentially chose 5 papers, not necessarily the most clinically impactful, but just sort of found the most interesting towards EMS. So some of these you may have heard about, some of them you may not have. But first one I feel like most people have heard about. I think we've actually talked about it on this podcast for a Monday afternoon journal club. Non-invasive ventilation for pre-oxygenation during emergency intubation, also known as the Pre-Oxy trial, came out in New England Journal of Medicine in June of this year. So the clinical question it was asking was, in critically ill patients undergoing tracheal intubation, does pre-oxygenation with non-invasive ventilation, so like BiPAP, CPAP, compared with pre-oxygenation with an oxygen mask to reduce the incidence of hypoxemia during intubation? Just some quick run through about the study. It was a multi-center randomized control trial, did 1-to-1 randomization, included any patient over 18, and they randomized about 1,300 patients in total, about 650 in each group. And the results actually were pretty cool. They found that the incidence of hypoxemia was lower with the non-invasive positive pressure group than the oxygen mask group. And then the thing I actually found most interesting about this was that the aspiration rates were very similar between groups. So historically, I remember even from being a paramedic and then through med school and then emergency medicine training, everyone was always like, oh, BiPAP, you have to be really careful with somebody with a lot of oral secretions or somebody that may not be as responsive just because they may have higher rates of aspiration and a higher risk of aspiration. And certainly is a thing to be concerned about. But that was one thing I remember when I heard about this study prior to the publication of its data. I was like, it would be interesting to see what the aspiration rates are because, they weren't necessarily controlling for mental status. And I definitely I'm sure both of us have, the other 2 people on this call have also put some folks on BiPAP where you're like, a little concerned that they may be aspirating on this BiPAP. So, I think it was 0.9% in the non-invasive group and 1.4% in the oxygen mask group. So slightly higher, but not statistically significant in the oxygen mask group. And there may be a lot of reasons to that. There may be some folks that they may have just put on the oxygen mask that were already at high aspiration risk where they didn't want to go to BiPAP or, well, actually, as I'm talking about that, they randomized these people. So never mind. But there probably is some non-statistical reason that was a little higher that doesn't really necessarily make clinical difference. But all that saying, the reason I selected this article, and I really like that, is that this was practice changing for me. I remember being a new paramedic, and that's when the Scott Weingart passive oxygenation stuff came out, and we were putting people on nasal cannula, non-rebreather, while setting up for intubation to denitrogenate. And that's sort of been my practice up until this paper came out. Because there's been a ton of folks that I've intubated that, I'm intubating for various reasons other than just respiratory support. And I wouldn't have necessarily pulled the non-invasive trigger to get them on like a BiPAP or CPAP prior to intubation. But I think with this reducing the incidence of hypoxemia, I consider it my standard now that if I'm intubating somebody, non-emergently, of course, if someone comes in crashing, non-emergently for an ER, I should clarify, or for EMS. We all know what I'm talking about. Then I would be inclined to put them on BiPAP or CPAP. And my recommendation for my EMS crews here, whenever I get a phone call similar to this, and like I said, my new practice is, if you have the resources in the pre-hospital environment between you and your partner, and you can manage both setting up for intubation and setting up a CPAP or BiPAP, then do it if feasible. If it's really not feasible, because sometimes there are those scenes where it's just the two of you, you have a patient that's shitting the bed, and the best you can do while you're setting up for intubations, a nasal cannula and a non-rebreather, then that's that. But if you can do it, then I would say this is probably practice changing. I know for me, it's not probably, it is practice changing for my EMS crews that we're going to be doing non-invasive prior to any intubation.
And it also kind of speaks to, we've talked about the glacial pace of progress here. The Weingart paper came out in 2011. So we're sitting here at the end of 2024, looking at a paper talking about, all right, well, maybe we should probably change something that was, sacrosanct for a while. Certainly when you and I were going through medical school, the idea of putting CPAP on somebody with an altermentation was, that was verboten. Like, you cannot do that under any circumstance. So I guess the one question is, if they're looking at BiPAP here, if you're an EMS project and you generally have CPAP, would we see significant changes, or is that something that you think would apply to someone who only has CPAP?
My suspicion is there's probably still changes. I think that, at least for this population, most of the benefit is from the CPAP, not the extra inspiratory PAP. It's more than what was tested here, right? They had like minimum settings of 10/5 for this population, but I think there's likely still a benefit.
Yeah, I would agree with that. For our crews out here, we only have CPAP, we don't have BiPAP, and that's sort of been my way of going about it. And I think Mike hits the nail on the head. I think just getting constant positive pressure, keep those alveoli open, denitrogenate. That would be my guess. That's probably what the leading physiological benefit is of this. It's not necessarily the delta pressure. I would agree with the other good Dr. Mike.
And Mike Stone, Mike DeFilippo had mentioned that, this is something that's practice changing for him. Have you seen those same effects in your practice?
So not so much. I think I'm a little bit more hesitant about this article, and I think to me, kind of like lies in the people they didn't study. I think I think the big lesson for me here is patient selection. They studied 1,300 people, right? It was like 600 something people in each arm, but they excluded a bunch of people, and I think it was like almost half the total evaluated people were excluded. And I think the very important population that was excluded was those with poor mental status who were deemed too obtunded for BiPAP, or those who were deemed high risk for aspiration, or who were, quote, too urgently needed to be intubated, right? And so like 924 people were excluded because they needed to be tubed faster than what was thought. And I think a lot of the population of basically patients who needs tubes in the pre-hospital setting probably fall into the excluded group. I think that's a big caveat. And so I asked myself, like, do I have 10 minutes to intubate this person, or do I have 90 seconds to intubate this person? And then that's
actually a fairly interesting point, and I think also probably is evident of our different practice environments, because you're working in an urban area. I have a very large rural catchment area where our average transport time for some of these rural agencies is like an hour and 45 minutes, if not more. I think you actually also hit the nail on the head that, some of these patients where you can watch and wait for a little bit, see how they respond to non-invasive, or, whatever other intervention you're doing, definitely a good thing to do while you're doing that. But you are very right about those excluded groups and who was taken out. And, it would be interesting to see not excluding those patients who need emergent intubation, because that also brings another aspect into it of how quickly you can set up the CPAP or BiPAP or whatever without impeding your intubation as well.
And it's an important discussion point in EMS where it's one of the harder points with these data points, right? It's when we see something in an ER, we have to try to kind of extrapolate it into EMS, right? And I think Dr. DeFilippo is right, where you talk about having a longer transport time, maybe you have a little bit more time to kind of sit with the patient and see how that pathology is evolving, right? So you can actually trial someone on CPAP first while you're moving toward intubation. I think a lot of times in more consolidated settings and urban settings, we might be faster to intubate in the field because we know that the ER might be busy, or that's probably what the path is going to be anyway. So it's an interesting observation that the setting might actually change this too. And as Danny and I have talked about, that's kind of the fun thing about reading this data, right? Is this is a good data set. This is a good study. And there's plenty of other things that still need to be researched. But for the time being, this might be something you have to consider in your arsenal before you actually do an RSI. So as we're looking at this, and again, something that we've talked about a lot on the show, this next one is early intramuscular adrenaline administration is associated with improved survival from out-of-hospital cardiac arrest because, say it with me, we have no idea what we're doing for cardiac arrest. So this is coming out of Resuscitation. This came out in August. Mike, what do we have for this guy?
Yeah, so this was actually out of Salt Lake City. I had the pleasure of having a journal club with two of the authors of this study last month, which was great, having some discussion with them. But this was, as you said, published in Resuscitation in August of 2024. The clinical question they were asking was, in out-of-hospital cardiac arrest, does IM or intramuscular epinephrine followed by standard IV or IO epinephrine improve survival? So it was a single-center urban two-tiered EMS agency, Salt Lake City Fire, and then EMS, in adult non-traumatic out-of-hospital cardiac arrest. Their protocol called for 5 milligrams of intramuscular epinephrine, followed then by IV or IO epinephrine, 1 milligram, 1 in 10,000, every 3 to 5 minutes following ACLS protocol. They were able to enroll 1,400 patients, 400 in the IM group, 980 in the IVIO group, and they found increased survival in the IM group of 37.1% compared to 31.6 compared to, I don't have it listed here, sorry, but 37.1% in the IM group. And then interestingly also found increased favorable neurological outcomes in the IM group, 9.8% compared to the IVIO, which was 6.2. So, I think just a couple interesting things about this study for me. I think it was a super novel idea. I think the question of time to first epinephrine is a really good question for cardiac arrest management, because there's always, I feel like epinephrine is the yin and yang of cardiac arrest research. Any study that comes out that says epinephrine is useless, like 2 months later, there's another study comes out that's like, epinephrine is the silver bullet.
It works. We need to give more.
Yeah. So, I think there's a lot of aspects of epinephrine that we really still don't know about in cardiac arrest care. And I think this idea of can we get it faster and does the route of administration matter was really cool. There was a couple of things that I think really limited this study. The sample size is a little small and a little disparate between both groups. There were some protocol deviations because COVID-19 started happening, that little dang thing. So, but I think, this study as a EMS researcher, I was like, hell yeah, I can't wait to, talk to my IRB to try to do a randomized study on this. Because I think really for me, is this practice changing? Not necessarily. I'm not going to go out there and tell all my crews to start, slamming IM epinephrine or giving my BLS crews IM epinephrine for cardiac.
And it's 5 milligrams too. Like it's not a little bit of epinephrine they gave.
Right. And yeah. I think, for me, again, I think the question's really interesting. Like how fast does epi need to be administered from time of first cardiac arrest? And also, I think there's lots of public health implications for this, which are really cool. Like, epinephrine's a pretty easily storable, easily movable medication when packaged appropriately. And I can foresee a future, should this bear out in the literature to be true, of an AED packed with IM epi. As soon as you open up the AED, you put it on and then you slam somebody's thigh with some epi and you call 911. Like, I think there's a lot of cool things that can happen from this study. I just think there needs to be a lot more research. But I really applaud the authors of this one. I think it's a very unique and very, innovative design and study.
Dr. Stone, what do you think?
I totally agree. To me, this one is like beautifully crafted foundations, right? I don't think this is ready for anybody else to fully implement this protocol in, but it's a masterwork in getting the right data to then let them answer the real question, right? Which is, to me at least, can we put IM epi on BLS rigs? Because I think, like, if you look at the Resuscitation's Outcomes Consortium, 53% of cardiac arrests, BLS is on scene first, right?
Right.
In many other systems, 10 to 20% of arrests have BLS first. And so there's like a big population where this could benefit and actually change outcomes for once in a decade or two.
And I think that's probably the closest to right. What excites me, and Mike DeFilippo, you were talking about this, is let's say that this does bear out, right? If we're trying to get people to perform CPR in cardiac arrest, we have to make it easier for them to perform things that are going to improve outcomes. And I can't think of an easier way, save maybe an intranasal medication, than giving an IM med, throwing on an AED and doing CPR. And we talked about this on journal clubs previously, where, there's also the question of naloxone in cardiac arrest. So with data like this, can this lead to, let's create a pack where we have an AED, we have naloxone, we have epinephrine, and whatever. We have one at 5 milligrams, one of 0.3 milligrams for anaphylaxis. Can we start involving those kind of into a bundle and putting those out to the public? I think that kind of question is really the interesting outcomes from stuff like this. But even then, save all of the public health stuff. This kind of shows that it is possible to put supplies onto BLS ambulances and improve outcomes without getting into all the fancy talk about what people like us would do out on the road working as medics, right? This is something where it's like, okay, if you're an EMT and you know how to give an EpiPen, here's a higher concentration of epi, AED, epi, do your thing. People will, at least as for what the data says, people will survive a little bit better.
I do echo your point real quick, because I'm a stickler for this part, especially when it comes to talking about cardiac arrest research and outcomes. And I'm glad you brought up the naloxone article. I think a lot of these articles that show benefit like this, they're obviously studying one thing. In this case, it was epinephrine. But I really think, the key to great cardiac arrest survival, and we'll get to this a little later with one of the other papers, is sort of like a bundled approach to care. Very similar in the way I like to explain to other people is, if you've ever rotated through an ICU or shadowed an ICU doctor or whatever, you'll hear someone say, oh, make sure the vent bundle is in. Order them the vent bundle if they're intubated, blah, 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 blah. And for those who may not be unfamiliar, the vent bundle is a whole bundle. And when we're talking about a bundle, what that means is a combination of orders, a combination of clinical practice guidelines, a combination of medications, a combination of maybe radiology imaging or other interventions. Not necessarily one thing, but a bundle of care that has been studied and shown to improve an outcome of something. And for example, in ICU patients, those vent bundles have been shown to decrease rates of ventilator-acquired pneumonia and oral infections and all these other maladies that intubated people get. And I really think, cardiac arrest research is showing that there is not necessarily one, like I said earlier, silver bullet, but rather I think bundled care is going to be the way of the future. And I think anything that's innovative that cracks into how can we sort of change this bundle, and I think this IM Epi does a great job, is really what's going to cause major changes in cardiac arrest outcomes of both research and clinical practice. So thanks for bringing that up, Ed, and I'll get off that. So
I think all that's right. Mike Stone, I'm interested too, because I think some of the pushback to Dr. DeFilippo's point can be if you bundle something that doesn't allow you to practice medicine, right? That's doing checkbox medicine. So I wonder what your response to that would be in a setting like that, where, all right, these three things work. This is your resuscitation bundle. This is what we do.
It's hard to, that's a great question. I think it's really about splitting the difference, right? I think that we can't have it all one way, right? I think you're right. We can't have everything bundled and purely protocolized. And by the end of the day, if we know it works, it's also it needs to happen, right? And so I think there's kind of a mix, right, of making sure the things that we know scientifically matter happen, and letting our providers use their brains and make sure when those happen and how those happen. And sometimes what happens can be chosen, right? But it's all about a balance of your system, right? The skill level of your providers. And one of the things I liked about this bundle idea is that it came across really well in all the EPIC studies with isolated head trauma. Right? They had a great bundle study that showed significant improvement of outcomes. And so I agree.
I would also make the argument as far as how, because I can totally see that perspective too. Oh, this doc is telling me I just need to do all this now, and I can't even think anymore during cardiac arrest. I would say in particular for high intensity situations like cardiac arrest, where you're introducing something like bundles, I would view it less like a checkbox and more like a cognitive aid, in the sense that hey, all of these things need to happen because all of these things have shown to prove to take an RSI checklist or an RSI. I know it says not checklist, but take a RSI checklist as a cognitive aid during an RSI. It's not necessarily telling you what you can't do and have to do and all these other sort of things. The list of things to say, don't miss these key steps to help prevent major error or calamity during the RSI procedure. Same thing during cardiac arrest. This bundle, make sure all this is done. This has been the evidence-based stuff that's shown to improve care. And this is a cognitive aid. So now that you can think about all the other things, hey, why is this patient in an hour complex PEA for 15 minutes despite the bundle? Or, I'm hoping you're recognizing that sooner. And say let me do some other interventions or something like that. So that would be my take on that question.
And I think that's right. I think, I said checkbox, and I think checklist is probably closer to right, where here's 20 things you can do. You're not required to do all 20, but you have, standing orders or protocols or whatever to do all of these things based on your actual clinical judgment of this patient. I do think that that's something that could be important, where instead of being so stringent as to the barriers of what you can administer, use your clinical judgment, use your clinical acumen. Here's X amount of things that you can do for these patients. Speaking of drug route administration, we've got another one here. This is coming out of the New England Journal of Medicine. This is from Halloween this year, which I love that they're publishing data on Halloween. But this is talking about how we give drugs, the route of administration in cardiac arrest, and how they work. What do we think about this one, Mike? Oh, wait, hang on.
So this was, like you said, out of New England Journal in October of this year. The clinical question they were asking was, in adults experiencing out-of-hospital cardiac arrest, does an IO strategy for vascular access improve 30-day survival compared to an IV first strategy? So I think over the years, obviously, many routes of medication and administration have been used, IV, IO. If you're old enough, like I am, putting stuff down the tube, epi, if you can get access and all that other sort of stuff. So, and I think all of these approaches, similar to what we talked about with the IM epinephrine study, have the same goal of like, let's really crack in and see, does the time to first epinephrine or time to first drug administration really matter in these cardiac arrests? And so, again, this was a beautifully done study, multi-center randomized trial across 11 UK EMS systems, adult out-of-hospital cardiac arrest, 3,000 patients in each group. And God's honest truth, I was surprised by the results of this study. I would have bet a lot of money that IO would have been better than IV. Like, I was shocked. There was no significant difference between anything. But I think also good on the authors of the study and the journal for publishing a study without any statistically significant findings, because I do still think it has like some good clinical questions out there. One big thing that I actually found really odd in the study was how long it took them to get IV and IO in patients. The time of first access from provider on scene or clinician on scene was like 24 minutes. Like
Wow.
I understand, or 27 minutes, whatever it was. It was quite some time. I can't find it in my notes for whatever reason, but you have a cardiac arrest patient, and I'm not sure how the EMS systems in the UK work fully, to my knowledge. I understand that there's probably some practice variation, but again, I can't imagine a continental US-based EMS system for a cardiac arrest taking 20 plus minutes to get IO or IV access, even with just two partners focusing on BLS only in an ALS unit. I'm not exactly, and that would be my question for these authors would be, and again, I can't remember if they talked about this in the paper or not off the top of my head right now, but why so long for first access? Anecdotally here, like our crews are, and even where I worked in Jersey and in the New York City area, I feel like they're very proficient. Get on scene, someone's doing CPR, you may or may not have a third person doing airway, but a leg or an arm is exposed or the pelvis, and you have an IO within less than 10 minutes.
A minute, yeah. The last data that I saw said that from on scene to the first epinephrine is something like 9 minutes. So looking at this data set, I almost wonder if part of the problem was that, maybe these particular interventions weren't done in a timely fashion. If we're not getting access, then it doesn't really matter what medication we're giving or how we're giving it.
And again, I that's really a question I'm curious, and I would love if there's any listeners that work in the UK, and I know we do have them. I'm just curious the culture over there. Like, is it, because I can imagine a system, again, this is me postulating. I can imagine a system where we're like, we know CPR works, CPR and
Right.
AED works, and we're going to focus really good on just doing ELS only CPR for 20 minutes or something. And if we don't have any change after then we're going to do an IV or an IO or whatever. Or it may be, availability of ALS crews. I'm not exactly sure the system culture and the specificity of their system over there, but like, I just can't imagine. Like, I saw this study, and like I said, I was really excited to see it, and I was absolutely shocked. And then, the more I'm reading through it, I'm like, I really don't know if this is applicable to me as a US EMS doc.
Right.
That's such a long, like, I feel like if I saw that trend in my crews, that would be a conversation with the operations directors and the crews about like, what's going on.
Well, on our side of the pond, we kind of emphasize, like, you remember going through medic school where it was like O2 IV 12 lead, right? Like, those are the first that you will get vascular access quickly. So, and, it could be a cultural part of that, but Mike Stone, what do you think about all this? Are we using IVs over IOs now?
I was also really suspicious of those numbers. I'm on board with Mike here. I think that while the question of IV versus IO and cardiac arrest is a murky question with a very out of focus answer, what is pretty well known is that IOs are pretty reliably, on average, faster than IVs, and I feel like that should have showed itself in the data, and it's pretty suspicious that it didn't. I think there's probably a bunch of bias in there, which is hard to reconcile.
Yeah.
I was
And that
also
might be
surprised by the pilot.
it might be one of the first things that we have to talk about a lot more when we look through articles and we look through, journal papers and whatever, when it's always interesting to see what the results are. We talk about in Journal Club, one study is one study. You have to know, what it applies to. I like to see studies that say more data is required at the end of the study. Even if it's just a platitude, I like hearing at least recognizing, there's more stuff that has to be done here. When I see, this type of result, like, all right, IV is superior to or IO was non-inferior to IV. There's so much that goes into starting an IV on a patient that I think we take for granted, especially when you're in a cardiac arrest scenario. For me, I think about the timing of it, right? And the cognitive load, where my practice is I typically use a humeral head IO and an iGel frontline for cardiac arrest. Almost across the board, there's very few times I'll do an endotracheal tube first. Some of that is, it's data driven, and, I can pat myself on the back for saying that I read journals, but it's also easier. Like it's when I say the cognitive offloading thing, I mean, I do mean that in the truest sense of the term. I don't have to think about, how I'm going to put a 20 in someone's radial while also trying to manage their arm when it's up on the Lucas in the whole, like, I don't want to have to think about that. So it's interesting seeing these things. Like, maybe IV is better, but with this list of variables, it's really hard to actually know. We got 2 more papers coming to you. We'll be right back after this. Hey everybody, it's Ed, and I want to tell you about the Monday Afternoon Journal Club. It's a new thing we've been doing on the Overrun here on YouTube, and we're really excited about it. We've gotten a lot of really good feedback for it. What we're doing is we're taking new journal articles that have been published within the past year, 6 months, 3 months, and sometimes even the past couple weeks, and updating you about new EMS information, whether it's clinical care, response times, operations, all of those things. We're bringing you the newest EMS data. So subscribe to the Overrun on YouTube and check out the Monday Afternoon Journal Club most Monday afternoons. Now back to the show. All right, welcome back to our year-end review, and now we're going to talk about whole blood because that stuff costs money. Mike DeFilippo, what do we got here?
Yeah, so I thought this was a super interesting one, and not the typical whole blood article that you probably were expecting to hear that says whole blood saves lives and is needed in EMS and all that other sort of stuff. I think anybody who follows the literature or whatever would agree with that earlier blood and penetrating trauma in hemorrhagic shock patients is needed in the pre-hospital environment. Case closed. That would be my opinion. But what I thought was, and for those of you who are listening that may be protocol developers or innovators within your EMS system that are trying to get blood, really pay attention here, because this is the article that really will help you get a seat at the table to have that conversation. And that's really the issue we have as EMS docs too sometimes, especially when we're trying to do innovative stuff that costs money. So this was an article out of the American Journal of Surgery that was published in September of 2024 that asked the question, in adult trauma patients requiring massive transfusion protocols, we'll go over that in a second, does the use of whole blood compared to component-only resuscitation reduce cost, waste, and improve survival? Now, you may hear that and say, well, this doesn't really relate to EMS at all. This is comparing whole blood and component therapy in MTP patients. And let me just break down what all those are real quick, and then I'll go into talk about the study. So whenever a trauma patient comes in, or really any patient that's bleeding that needs a lot of blood, there's a protocol in most hospitals, if not every hospital that has a lot of blood, called a mass transfusion protocol, or MTP, or a mass resuscitation protocol. It has a lot of different terms, but all the same thing, meaning I've recognized a critically ill patient that's hemorrhaging, and I need to divert pretty much every available unit of blood in this hospital to this one patient. Every hospital I've worked at that has MTP, or mass transfusion protocol, the way it works is the lab literally shuts down and just focuses on your one patient for however long the resuscitation is. And it's a big decision to make as a doc, because generally other patients in the hospital can't get blood at that time. All the staff resources are focused on expediting clearance of units to get that patient blood. And also it's a huge resource lift. You have, blood runners coming in and out. You have generally, at least from an ED perspective, you have trauma surgery, anesthesia, you're trying to coordinate OR and all these other sorts of things for this patient while you're still at the bedside and just actively, pumping blood in, getting access, all this other sort of stuff. So just to set the frame of what a mass transfusion protocol is in a hospital, very resource intense and a lot of people and a lot of blood product. So it asks the question, does whole blood, meaning everything that's in blood in one bag, compared to component therapy, where it's split between red blood cells, platelets, and, oh my gosh, why am I freaking forgetting?
Plasma.
Thank you. So, and that's typically given one unit of platelet, 1 unit of plasma, 1 unit of PRBCs, and then you recycle that on a continuous loop while you're doing a resuscitation. So 3 different bags of blood product compared to 1 bag of blood product. And did this help not only just mortality, but reduce cost, waste, and improve survival? Now, why is this relevant for EMS? I feel like I'm like that Charlie Day meme with
all the red lines. Can we please talk about Pepe, Sylvia? I've been dying to talk about Pepe all day.
Yeah. So why is this relevant to EMS? So, EMS blood products now at this time, thankfully, are not new to the EMS world in the United States. The ideas have been out there. Non-EMS folks now know that EMS crews are giving blood in certain areas of the United States. But the real question is whole blood better than component therapy? It is. And then, this study asks now, is it more cost effective to carry whole blood? There's lots of things. I carry blood on my EMS response vehicle. I don't carry whole blood. I carry some PRBCs. But the flight program I fly at, we started carrying whole blood recently, and it's been a game changer. So this asks the question, is whole blood, cheaper and better than component therapy? Not only so, I'm getting too excited. Let me circle back over. Let's talk about the relevant metrics of the study. So it was a retrospective single center review at a community level 1 trauma center, so single site study. They enrolled a total of 570 patients, about 200 in the whole blood group, 375 in the component therapy group. And they were really looking at the total transfusion related costs. And then secondary things like the number of MTP activations, blood product waste, patient mortality, ICU length of stay, ventilator days, all those sorts of things. So all this to say, this is a really good article for you to print out because it showed a lot of positive benefits with whole blood. It showed a lot of cost savings. So the annual average cost saving of using whole blood for the single hospital was about $850,000. And when you extrapolated that to over 4 years, it was about $3.4 million worth of savings to the health system. They used about 25% less product. So sometimes, or rather, saved about 25% of unused product. So what will happen sometimes when you're running an MTP like this, you have a blood runner who's going to come run blood up to you wherever you're at, and it's going to sit there as the blood that's already being transfused is going in. And sometimes either the patient dies or the patient gets better and you're like, we don't need that blood anymore. We fixed the problem. And there's blood just sitting there. And sometimes, unfortunately, that blood gets too warm, needs to get thrown out or otherwise damaged, maybe spiked and ready to go and just never given. And as you can imagine with component therapy, where everything's split into different bags, that can happen a lot more. And this is the quantitative data to show that whole blood really saves a lot of unused product, which is great because that means that can go back into circulation. Blood is a very finite resource, and those resources can go to other patients that need it. It also showed about a 40% reduction in overall blood product waste and an over 50% reduction in MTP activations, which alone in this system saved about $200-something thousand. So that's just talking the finances of it. And then the patient outcomes, whole blood showed improved survival, about 20% reduction in mortality over 4 years, and that's a reduction in mortality despite about a 40% increase in the amount of patients they saw requiring all different types of blood products, but showed no significant difference in length of ICU or ventilator stays. All this to say, I need an Ativan. All this to say, this is a great paper to bring to the table if you are an EMS project that may have already blood product, if you're doing component therapy, or alternatively, you're in discussions right now with, your hospital blood team, the pathology department, your other systems administrators, and you're saying, okay, we've identified we want blood, right? But now the argument is, are we going to get whole blood or are we going to do component therapy? Either way you cut it, this is an excellent paper to bring to the table because administrators, directors, hospital people that are not in EMS love to talk in money. And you can say, hey, look, I know this is a single center study, but it was a very high volume trauma center. This was a really well-performed study. and it showed millions of dollars in saving by using whole blood therapy. And the reason I chose this article for us to talk about on this EMS Research Articles podcast is because I think this is really impactful for those of us who are movers and shakers in our systems. This is a good paper to bring to the table to your county administrator who may be, giving you some money to your department to help offset hospital costs. This is a good paper to bring to your protocol developers, to your medical director, and say, hey, look, I know we're talking about PRBCs, but have we considered whole blood? Here's this paper, that if you, as me as a medical director, if one of my medics or EMTs brought this to me, I'd be like, holy shit, thanks. This is awesome.
Yep.
Because this is going to be
certainly
hospital people about.
And certainly the environment has to be taken into consideration too. This paper came out of Spartanburg, South Carolina, which I'm not here to cast aspersions on how Spartanburg, South Carolina works, but I'm certain that their budget isn't as significant as, say, New York City or Miami or Dallas or Los Angeles. So it's more important, I would say, for smaller organizations to be able to save this much money. Dr. Stone, what do you think?
I completely agree. And I think that this is almost as impactful, I guess, the RCTs to me, right? Like at the end of the day, we can know something scientifically works, but we have to come to the administrators, right? To the cities, to the counties, to the departments and say, hey, I want to start this expensive treatment, which I know saves lives, but we can't get any money back for it, right? Pre-hospital blood is not a billable procedure at this time. At the end of the day, they got to balance the checkbooks. And I think this is the thing that helps change happen.
No, and that is one of the biggest things, right? Is if you're in a system and you're a leader and you're trying to implement new practices, if you go up to an organization, especially if you're in a hospital-based system, the municipal systems and town and county-based are hard enough to get through that bureaucracy. But if you're in a private system and you work for a hospital or you work for an independent provider, this is where you're going to see that kind of difference where, here I have $800,000 for you that we can save by improving outcomes in patients. It's not something that you hear about all that often, and it should be more exciting for more people where this is something that is a win-win-win for everybody, right? It benefits everyone within the system. There's a lot of talk always about trying to benefit patients first, which should always be our goal, but there is a reality that exists where people are going to want to see what the money is, right? We need to see savings, we need to see profits in some systems, and I think this is a good one to actually introduce to try and make some change. And now, because we love us some cardiac arrest studies, Mike, we're going to do one last one here and another cardiac arrest study here. Let me bring it up on the screen. We're talking about EMS agency practices and cardiac arrest survival. This involves a couple friends from the show. And what do we got here, Mike?
So this, if I had to choose my favorite article from 2024, I think this would be it. And that's because, I don't know, I'm an education guy, I'm a cardiac arrest guy, and I feel like this really brought those two things together. So, you may have, I think we talked about this on the show previously. I've written a blog post about this, how much I like this article. It's called Emergency, came out at JAMA Cardiology, August of 2024. And it really reviewed what agency practices are associated with better cardiac arrest survival. They reviewed 500 EMS agencies, which covered over 50% of the U.S. population, to identify practices linked to improved survival and neurological outcome in out-of-hospital cardiac arrest. And they identified 3 key domains encompassing 7 practices that were associated with improved outcomes. So the first domain was training. They found the following things: simulation-based training, regular CPR skills assessment, and team-based scenario simulations were shown in systems to have improved cardiac arrest survival. Now, I think that's awesome. As an EMS educator, like that's sort of my niche within EMS, I think this is great. I'm also a big sim guy. What does this really tell me? I think this is great for all systems, whether or not you're a system that runs a ton of cardiac arrests a day, or you're a system that may see a couple of cardiac arrests a year. I think this is some great foundational educational stuff to bring to your system. If you're an educator that's listening to this, if you just aren't, a regular, I come up, I clock in, I clock out and go home guy, but you love cardiac arrest and you want to see your agency succeed, this is a great thing. Essentially, more training is associated with better cardiac arrest survival. The more you do sim-based training, the more you do team-centered training, the more you do CPR skill-focused refreshers, making sure that your medic of 20 years still knows to do appropriate CPR, making sure your crews are really good at their communication, like actually having multidisciplinary. And what I mean by that within EMS is, have your fire folks there if you're on a multi-agency organization, have your police folks there. try for these like multi-interdepartmental simulation days to really enhance your cardiac arrest survival. And I just love that aspect of it because I think it's really overlooked sometimes, like how big of a difference great teamwork makes on really high stakes calls like cardiac arrest. So that was sort of the first bucket. The second bucket was with CPR. They found mechanical CPR device training, not necessarily mechanical CPR devices, training and CPR feedback or impedance devices were both also linked with improved cardiac arrest survival. Again, this makes a lot of sense to me. I think we've all been on a cardiac arrest where we're like, holy shit, what is taking 9 years to put the device on? And why are we off the chest for 4 minutes? Right?
Yeah.
Like we've all been there. So, obviously training to get those devices on helps a lot. Training to troubleshoot those devices helps a lot. Just like, learning CPR, learning how to put the Lucas on or learning how to put whatever compressor device you have on is its own distinct skill. And practicing that is necessary for better survival. And I'm a huge fan of impedance devices and feedback devices. And I was glad that they showed some improvement with survival in this article. For those of you who may be unfamiliar, those CPR impedance devices, hello.
Hey.
If you didn't catch that, rewind about 10 seconds, are great. So it tells you, are you giving enough chest recoil? Are you compressing deep enough? Are you compressing at a fast enough rate? Like I think, agencies that use that, in my experience, are really top notch. And I love that, again, that they focused on that in this study. And then lastly, I was a little surprised by this, but also not surprised, was transporting. So not necessarily transporting patients in cardiac arrest, but after the patients who have achieved ROS, transporting them to a designated cardiac arrest or STEMI center was associated with better outcomes. Now, does every patient that is a ROSC need to be diverted to a cardiac arrest or STEMI center based off this? I do not think so. And again, that's a very real question for where I practice right now. Like I said, I have a huge rural catchment area, and that's a huge decision sometimes for these crews. I'm not necessarily diverting those crews from the critical access hospital where they can get early definitive care to go to a STEMI or cardiac center. What I gleaned from this, again, goes back to that teamwork aspect of things. Those cardiac arrest centers, STEMI centers are used to seeing higher acuity patients, used to seeing sicker cardiac patients, and likely by default, because of that, deal with more cardiac arrests with higher frequency and probably are better at the post-ROS care. So again, I think, this study was fantastic for me and my favorite paper of 2024 because it shows that regular high quality training, CPR techniques and assessments, and strategic transport decisions on a systems level can help improve outcomes. And for those of us who consider ourselves EMS educators, it is a really pivotal thing for us to hammer home points.
And this is something that I think has, you got all that wind out?
Yeah.
This is something I think has been, at least anecdotally, I've had conversations with people about, in hospital, I don't want to say it's easy, but it's much easier than an EMS, right? If I want to run a sim in a hospital, I can gather everyone. We run up to an exam room real quick, run through a sim scenario. We're back out, in the hospital. That's how a lot of residencies work, right? You have morning sessions, then you go and you do your clinic. In EMS, I'm not convinced that we have enough time to really go out and do these things. What I like about this is suggesting, all right, you know what? We can do training with equipment you already have, right? I can go out and I can take a unit, like, listen, we're going to run pit crew CPR or whatever you want to say for 5 minutes real quick outside. It doesn't take the unit out of service. It keeps everyone up on their skills. But it's interesting to me that it feels like in life, we talk about, practice doesn't make perfect, perfect practice makes perfect, but we don't necessarily apply it to EMS. Dr. Stone, what are your thoughts?
I really like this article. I think it's definitely practice changing. And I think to me, I like seeing when things we know by intuition are true, like kind of actually are proven, right? And like show out like when someone looks at it under a microscope. And while I'm a big fan of each of the kind of like domains, right? Like training, CPR, transport to STEMI centers. I think the other kind of like nice bonus to this is that they looked at like the systems and places that maybe didn't cover those specific items, but showed a focus on other items, also had better outcomes. And I think that's really reassuring, right? It's not that you have to do this, but I think that like if your department shows an interest and puts effort into improving this in every way possible, like you will see a benefit.
Yeah.
Right. And I think that a lot of the difficulty is like, right, like maybe I can't afford impedance devices right now, I might as well not improve anything at all, right? And it's like
Yeah.
just doing everything you can and actually getting through to that
Yeah.
also is going to help, right? Even if you can't do it perfectly. I think that's really important.
And I think that's an important, something is better than nothing kind of argument, where if you can't get impedance threshold devices, if you can't get certain, extra items, you can't get IM epi, whatever else, if you can just drill a team to do really effective CPR, right? To get in, get the hands on the chest really early, get the Lucas or the Autopulse or whatever device you're using on very quickly, just drilling that will improve outcomes without actually adding new protocols or new medications or anything like that. And it's interesting to me that culturally, we needed something published saying that practice will make you better. But I'm glad that we actually have this documented now where like, hey, if you actually train on these things, it is quantifiably improved in the data. This is the last episode we have for 2024. We've got a lot of really exciting stuff coming up in 2025. Mike and Mike, thank you so much for coming on and talking about the best papers from the year. Be sure that you follow us on Spotify, YouTube, Apple Podcasts, and everywhere else. We have podcasts and educational sessions and all this other stuff. For everyone here at the Overrun, it's been a really great year. Thank you again for joining. Thank you again for watching. And we'll talk to you in 2025.